All right, can everyone see that okay?
Yeah.
So hi everyone, my name is India Dasbach. I'm a fourth year medical student at Dartmouth and a global surgery research scholar at the University of Utah for this year, working with Dr. Nunez. Thank you all so much for having me. I've learned so much through this project and through the Center for Global Surgery already, and I'm really excited to share our data with you all. Today, I'll be presenting on our work on measuring the financial risk of surgery in Ghana. So as I'm sure all of you are aware, in 2015, the Lancet Commission on Global Surgery was published, indicating that greater than 5 billion people globally don't have access to safe, affordable surgical care when they need it, with the highest unmet need being in sub-Saharan Africa and South Asia. As part of this landmark paper in global surgery, the Lancet Commission put forth 6 indicators for the purpose of reporting and tracking by all countries for global health organizations in order to understand and measure the status of countries in terms of surgical access. The data was meant to be used to inform national planning to be able to appropriately compare across countries and to track progress over time. So to go over these indicators, the first one is access to timely essential surgery, so access within 2 hours. The second one is specialist workforce density or number of surgeons. The third is surgical volume. The fourth is perioperative mortality, and the fifth and sixth were both financial indicators. The first being impoverishing expenditure, or the proportion of households protected from impoverishment from the cost of surgical care, and then catastrophic health expenditure, which I'll expand on more later. In terms of the financial risk of surgery specifically, another important paper by Mark Schreim in 2015 followed the Lancet Commission and developed a model in order to develop a way to calculate an estimate for catastrophic health expenditure in different countries. This paper used World Bank data for each of the necessary parameters in 199 countries, and GDP per capita was used as a proxy if household data was not available. They used the WHO choice estimates for the unit cost of a C-section to represent the cost of all surgery. Unsurprisingly, the map of risk of catastrophic health expenditure aligns with the map for lack of access to surgical care in the Lancet. And this modeling study was an important way for people to be able to initially understand the access to surgery financially in different countries, but it also has its flaws in that it's a modeling study. It's not using actual reported data from countries, and it also uses the cost of a C-section to represent all surgery. So after the Lancet Commission was published in 2015, an analysis by an international group of global surgery researchers in 2019 found that despite a positive reception on the importance of global surgery following this Lancet paper, none of the indicators were being routinely collected and reported to the WHO. And instead, academics, societies, and NGOs were compiling some of the data on surgical care. But there was a lack of standardization, limiting the utility of data reported, and the data availability remained low. So in order to address this, the Utstein Perioperative Metrics Project was formed to address this problem. And this is a group of global experts who convened in July of 2019, with discussions continuing through August of 2020 to evaluate and explicitly define these indicators. They also agreed upon data points needed for construction of each indicator at the current time, which is the basic level data, and as countries are able to develop systems for collecting more data over time in 2 to 5 years and then greater than 5-year timeframes. They also condensed the indicators and removed impoverishing expenditure from the 2 financial risk indicators and limited financial risk protection to be measured by catastrophic health expenditure. So after this consensus report was published by the Utstein group, a research group led by Dr. Nunez from the University of Utah and Dr. Giadu from Kwame Nkrumah University in Ghana, sought to assess the collection of these newly defined indicators and assess its feasibility in terms of implementing the new Utstein methods in Ghana, a lower middle income country with advanced data infrastructure. Ghana specifically was selected as a test site due to its demographics, economic conditions, and health information system structure, which were a practical testing ground for these newly refined indicators. Data from the Ghana Health Service and Ghana Statistical Service were used to calculate the indicators at the basic level. And then for the fifth indicator, or financial risk protection, a prospective patient exit survey was used instead of using national data sources. And a survey is recommended for financial data collection by the Utstein group, as it's the most accurate way to find out what people truly spent on surgical care. And since the survey was already being done, Dr. Nunez's group made the survey more advanced than the basic level and collected data at the time of discharge, and then follow up 1 month later and collected data at the basic, intermediate, and full levels, in addition to some more expanded financial data. So I've been talking about the term catastrophic health expenditure as a measure of financial risk protection. And I just wanted to break it down in terms of explaining what it means. So there are several ways to calculate financial risk, but catastrophic health expenditure has been deemed the most appropriate and widespread measure for calculating and measuring financial risk. And in calculating catastrophic health expenditure, there are two main methods that are used, and I'll just touch on this briefly, but the first is called the budget share approach, which you can see here on the left is when out-of-pocket payments divided by total health expenditure or income is greater than a certain threshold, and generally it's been accepted to be 10%. There's also a capacity to pay approach, which takes into account people's spending on basic needs and removes that from the total expenditure. But this is a little bit more complicated to collect and is not routinely used in low and middle income countries. But if you're coming across data or papers in the US that are measuring catastrophic health expenditure, it might use this method. But the budget share approach has been widely accepted for use in global health and global surgery. And this method, just to reiterate, is that out-of-pocket payments divided by total expenditure or income greater than a certain threshold, which is generally, most commonly, 10% is the threshold that's used. And this is the method that's recommended by the Utstein group as well. It's also important to think about what data sources are being used to be put into this equation for catastrophic health expenditure calculation. So for the out-of-pocket costs of surgery, a patient discharge survey is much more accurate and preferred over hospital billing needs or records from national accounts, because it directly asks people what they paid. And in some studies that have been done before this, they have used hospital billing records or insurance records to calculate CHE, but because it's easier to get that data than doing a survey, but the preferred method is a discharge survey. And then household expenditure income is usually comes from a nationally representative survey, such as the Census Bureau in the US, or in Ghana, it's the Population Housing Census and the Living Standards Survey. Additionally, in considering out-of-pocket costs, there's lots of ways to include or not include various costs associated with surgical care, which has an impact on the calculation and then the impact on the value that you get afterwards. So direct medical costs are the costs of medical care provided specifically. So medicine, surgery and procedures, medical supplies used. Direct non-medical costs are those associated with obtaining medical care, including lodging or food during the hospital stay or transport to the hospital. And indirect costs are associated with, are more opportunity costs associated with obtaining medical care, such as loss of earnings from missed work, loss of crops if you are a farmer. And in most studies, only direct medical costs are considered, mostly because it's easier to collect this kind of data and it's more standardized. But there have been some studies that have already demonstrated that considering costs beyond just the direct medical care can have a big impact on financial risk calculation. For example, in Schreim's modeling study that I was discussing earlier, globally, it estimated that 33 million people face catastrophic health expenditure when considering just direct medical costs. But when you consider indirect costs and direct non-medical costs, an additional 48 million people face catastrophic health expenditure. And there have been some other studies showing similar results. So putting all of this information together, I wanted to go through the Utstein indicator data levels for financial risk specifically. So at the basic level, which should be able to be collected in 2 years for a country, this is the direct medical out-of-pocket expenditure and household expenditure for C-sections specifically. And C-sections are used at the basic level to approximate financial access to surgical care. At the intermediate level, which should be able to be collected in 2 to 5 years, it expands to include, in addition to C-sections, long bone fracture repair and exploratory laparotomy as other procedures, and also pediatric surgeries. And just to note, the pediatric surgery portion wasn't fully outlined when the project in Ghana was started, so pediatric surgeries were not included in our study, which is a limitation. And then at the full level, which could take up to greater than 5 years to collect, this should include an expanded list of interventions on the Utstein procedure list. And for this, again, the Utstein full procedure list has not yet been published. So in our study, we used cesarean section, long bone fracture fixation, and exploratory laparotomy. But additionally, at the full level data, direct non-medical costs are considered, and geographic disaggregation is also data that needs to be reported. Okay, so data so far at the basic level, direct medical out-of-pocket expenditure for related to cesarean section procedures. The median cost of a C-section is 910 Ghanaian cedi, and there's about 14 cedi to 1 USD, so this makes it approximately $61. And to put this in context, the median household income across all of Ghana is approximately $700, though great variations exist between different regions and communities. The incidence of catastrophic health expenditure was 10.6%, and then the national risk, which is an absolute risk, is 0.231, meaning 23% of people who have a C-section are at risk for catastrophic health expenditure in Ghana. Then at the intermediate level, we've expanded on to include laparotomy and open fracture. And as you can see from this data, the median costs are increased for both laparotomy and open fracture compared to C-section, as well as the incidence and risk of catastrophic health expenditure, further just showing the significance of including other surgical procedures and not just relying on cesarean section to represent the cost of all surgery. And then for the full level data, you can see again that when you're considering more information, the financial risk is greater, both in terms of the medical costs, the incidence of catastrophic health expenditure, and the absolute risk. And this data is immediate and 30-day follow-up, direct medical costs, and transit costs. And this is just here on the left is a map of different regions in Ghana. I don't have the geographic variation pulled up, but we did find variation in the different regions that were surveyed, with the highest risk areas being in the Upper West and Upper East and Northern regions, Brong, Ahafo, and Volta regions. So addition to the Utstein's defined terms of measuring financial risk, there's other calculations that can give more in-depth information about financial access to surgery in a population. And in this prospective study, we, or Dr. Nunez and the team, included some more questions beyond the Utstein list to get some more financial data. So one of these is catastrophic total cost. And this measure was developed by the WHO for tuberculosis care, in that people with tuberculosis have a longitudinal treatment, and there's often a lot of non-medical and indirect costs associated with coming in over a long period of time for care. And what it does is it uses the same budget share approach calculation, but it moves the threshold up to 20%. And then it also includes non-medical and indirect costs in that calculation. And this idea has not yet been explored in surgical care, but the longitudinal aspect of some surgery patients, such as those with a long bone fracture or abdominal catastrophe, suggests that they too would incur a significant financial burden over time with this longitudinal treatment. So that is something we looked into. Additionally, impoverishing expenditure, which was removed from the Utstein indicator list, but can also give more information about financial access to surgery. So that's when the out-of-pocket spending will cause someone to go below the poverty line. And then a third idea is the proportion of people below the poverty line who are pushed further into poverty. So anyone who has to spend any amount on surgery when they're already below the poverty line. And we've calculated some of this data so far. Here you can see that this includes the direct and indirect costs and 30-day follow-up data, all showing increased risk and increased costs of the 3 surgical procedures, and with some different information in terms of who is at risk for the catastrophic total cost versus the catastrophic health expenditure, with the 10% threshold and 20% threshold. And with all this data, we have 4 papers that are planned and in process. So the first is the feasibility study of collecting the Utstein indicators, and that manuscript has been written and is with authors for review before submission. And then 2 manuscripts are in progress. One is reporting all of the Utstein indicators at the basic level. And then the third is a paper really focused on this financial risk analysis at all Utstein levels, and then including some additional information that discusses the including indirect costs and catastrophic total cost. And then the final paper is for the future, discussing impoverishing expenditure and then expenditure for people below the poverty line who are pushed further into poverty. Some references from the presentation. And thank you, everyone. I know that was a quick overview of some detailed topics, so happy for any questions or comments.
Great, what a fantastic project. Dr. Nunez, do you want to take the lead? Your comments on the work, anything that you want to highlight?
First of all, I want to applaud India for a really excellent presentation on a pretty complex topic. And it's been a real pleasure to work with. She sort of just kind of jumped in with both feet, and to mix metaphors, sort of drinking from the fire hydrant, and she really just digested all of it, and it really has understood it very quickly. And so she's done a really admirable job. As you guys can see, this is just illustrative on why the Utstein process had to happen. There have been, a lot of reports on various indicators, much fewer comprehensive reports all at once of all 5 or 6 indicators. And you can't really compare them. If you just look at catastrophic health expenditure, some people were using non-medical costs, some weren't. Much fewer have taken into account indirect costs. It's much harder to measure, especially in lower middle income countries. Different data sources have been used, different thresholds, even in the United States, where sort of there are arguments for using the different calculation method based on different settings. And so the Utstein was about sort of making everything comparable, but also sort of tailoring it to different settings. And once again, it was an iterative process. And so, we working through emails and like updates to some of the recommendations and kind of parsing out differences between what we maybe have discussed in different task groups, writing groups, versus the actual consensus project or meeting versus sort of what came out in the sort of rough document. Now, the point of the second Utstein consensus, which is what this project was is meant to pilot, they are going to produce a toolkit to help ministries of health and universities in different countries to be able to sort of efficiently report these in a standardized way. But that's all waiting on some of our papers to come out between us and the South African team. And so I think this has been a really fruitful process for me and for our team, because as you know, you look into one question and then 12 more questions kind of pop into your head. And so as I've been doing this, and I've been doing this sort of the same type of work here in the US, I've got plenty of questions to answer moving forward. I see, I guess I'll open up for questions. It's Katie, thank you for the comment. I guess don't necessarily have a question.
I have a question. Are you comparing the prevalence or incidence of these different conditions with the costs? Because if you had, let's say, per 100,000 population, if you had 100 C-sections, but then only 10 leg fractures, then the potential for cost implications are different, right? And so, obviously, the proportion of people who are likely to suffer from C-sections, half the population, versus the proportion of patients who would be likely to suffer from a leg fracture are probably the ones that are more in urban setting and walking out to work or whatever. And so we have, to what degree do we need to think about the population burden of these conditions in matching them to the costs?
I think that's a great idea. We've not gone that direction yet, but that seems like a productive way to go. Just anecdotally, or just from the data that we collected, we were collecting in. We were focusing on one province and then kind of branched out. It was basically a nationally representative patient exit survey, and gosh, we probably collected. And did you recall how many patients were in there? I want to say it was probably 12 to 1,500 patients total, and 800 of them were C-sections. I think it was about 12 or 1,300, and then the vast majority were C-sections. So I think that's just speaks to like how much more common that is.
Yeah, and I guess then the question becomes, how representative is that survey population of the patients who are likely to have operations, and what sites do they represent across the country, et cetera, because maybe it was easier to capture the C-section folks versus the open fracture folks. Like, could they have access to care at different levels of the health system? And so, like, did the survey capture information from various levels? Would be another question. And then I guess the last question is, to what degree does your project capture any costs associated with referral systems? Because in lots of parts of the African continent, which is the only continent I know in any depth with this kind of data, is that there are very specific processes for referring people through the health system. And so there, and it varies, the conditions the referral systems for the conditions really can vary even within country and across countries. So some countries may have a more expedited process for C-sections, but not so much for trauma. Or other countries might not have any for either. So any thoughts on how that could be, how that was incorporated or could be incorporated or could be assessed? And again, like, as you said, there are 1,000 questions you can come up with as you discuss these things.
Exactly.
You know, it raises more questions than answers, but still, you know, useful to think about.
I would say that I think that's in a way that was captured because we were interviewing patients before they left the hospital, and for better or worse, in Ghana, it seems you can't leave the hospital until you pay. And so we at least collected at the point of care, and there were questions both at discharge and for follow-up, sort of care, questions related to care you got in follow-up, and also sort of indirect or non-medical type questions, really every kind of question related to how you got there. So transportation questions. So I think we didn't look at that specifically, but we would have captured all the costs on the patient, kind of almost no matter what. It was also another strength of the study design was that we did look at every level of hospital that performs surgery. So there were, I think one tertiary, a couple of secondary, and then some more district level hospitals. So definitely a robust process. One question we were trying to answer in the feasibility report is, is this reasonable to do and how often? I mean, obviously people prefer national health accounts or hospital billing. We even prefer that in the US. And to do a patient exit survey is a ton of work. It was definitely the bulk of our budget and time. And so we're basically recommending saying that it was feasible, we could do it. It may be best done as something performed every few years and not, or as part of like routine processes, cross-sectional across procedures. I think would probably be the way to go. But not something that necessarily happens every single year of one big cluster collection or something. But I think it is important to delineate, to emphasize its superiority over billing data because it doesn't capture every cost, and what the hospital bills may be different from what a patient pays.
Well, that's what I was going to ask you next is to what degree do you think it actually accurately captured the sort of under the table costs, the additional costs that patients may need to pay, because that's often not in hospital
That's right.
bills and stuff. But this is a survey, right? So you can ask people that information. Whether they'll truthfully tell you that information is a different story. But you can, can you comment on that aspect?
We asked, I believe we asked that question. We tried specifically to ask it on a study in a collection in Mongolia because as a post-Soviet country, it's and the one I'm more familiar with. It's extremely common to sort of tip or incentivize your provider, whether it's because the surgeon doesn't get paid very much and everyone knows it, so that's part of the system, or if it's sort of a power dynamic, and people just wouldn't answer. So I think I would suspect that around where this is a common practice, I suspect it would be very difficult to collect.
Other questions?
But yeah, that's.
Sorry, Jade, didn't mean to cut you off.
Oh no, that's okay. It's I'm blanking on the name. Informal payments.
Informal payments, yes. What a lovely euphemism. Comments from others or questions? Can't be the only person with questions.
I'll say that the last paper that India mentioned is going to be a sort of research letter in response to, so I was able to really geek out on this the past couple of years, and ran across a paper out of the World Bank, and Adam Wagstaff team, who's since passed. He's an economist for WHO and World Bank, and he sort of calls into question the utility of what catastrophic expenditure is for versus impoverishing expenditure. In the U.S. here, we have more commonly use the 40% approach, the capacity to pay. And the reason we use that is much more complex and probably not appropriate for most LMICs, but we use it. The argument is because it can better capture what impoverishing expenditure is meant to capture. And so Dr. Wagstaff argued, don't use it at all. For catastrophic expenditure, that needs to be just the relative amount of stress, financial toxicity put on a patient, and use impoverishing expenditure for the other bit. That tells you the proportion of people that fell below the poverty line. That still leaves all the people who are already living below the poverty line. What happens to them? And so Dr. Wagstaff's team, after he passed, recommended a third metric there, which was the proportion of people driven further into poverty. And so that fourth paper will, I think, be structured as a research letter to the WHO bulletin, sort of in response to that 2021 report. And I haven't seen much engagement with that paper, but I just found it fascinating.
So I just got a question for India, and that is, by doing this project, what do you think you learned from this project, and how are you going to use that for further research projects?
Yeah, I think that's a great question. I had heard of the Lancet Commission on Global Surgery, but I hadn't really fully understood what the indicators meant and how to apply them. And I really didn't know very much about financial risk of surgery and the complexity of all of that. So I think I learned so much about the details and how to understand access and how complicated it is to assess access in different countries. I think in the future, I'm definitely interested in continuing doing global surgery research. And I think I don't have a specific project or idea in mind, but I think having a greater understanding of the indicators will help me come up with ideas or think about research in a different way.
Quick question. Is there any similar work that was done in the continent, whether it's in the same region or some other similar countries with similar demographies that you guys were looking at?
There's been similar work done in much of Africa as part of sort of these collections for the Lancet Commission. Most are, I would say that there are a handful of others doing sort of prospective surveys, but typically that's door-to-door heavy head surgery. It's not the strength of this in particular is that it's an exit survey. And the recall bias is drastically reduced. But I'd say that like financial toxicity and catastrophic expenditure work is a pretty mature field for economists and public health physicians around the world. But sort of the question of like narrowing down or standardizing it for surgical use and also expanding it for sort of in-country use or is underexplored. You may have gathered that we keep talking about the basic levels, and the basic level is to compare countries and across countries. But where all these other sort of more advanced metrics or methods are used, or looking at a certain procedure in a certain country, not necessarily comparable across borders. But overall, it's a pretty mature field, I think.
I guess the question is, how do you take this data and how do you influence policy, or how do you share it with policymakers? What discussions have you all had about that? And because I think the global surgery space sometimes gets beaten up by local folks across countries by saying it's just an academic endeavor. Like, you find out the burden of disease, you find out the cost of care, and what's happening with that information. And so what are your thoughts about that?
I think we make the reason we look at it is because the economic argument is so strong, and that's how the Lancet Commission based their argument was around the economic bits. And so if we can sort of make that personal, that's the best bit about data, is that you can make it personal, especially with something like C-sections, where everyone knows someone who's either has had or is facing a C-section or trauma or the like, and you can apply it to any procedure you like. And so, yeah, converting from just data to policy, I think, is the big question. Within our group, our conversations have been, how do we implement these as routine processes? And then we'll figure out the next step.
There be any sort of reports that are sent to the Ministry of Health or Ministry of Finance or anything along those lines, or what are your plans?
As part of this grant, there's we'll write a report to the Ministry of Health. I believe we also promised to do sort of a public-facing report as well.
That's great. Other questions or comments from others? Dr. Justina Elijah is a pediatric surgeon. She and I were sharing a text separately about how pediatrics is so often left out, and low and middle income countries demographically have a huge pediatric population. And we were speculating if you could look at just the long bone fracture category and see how many of those were children, to kind of try to get some sense of the burden of cost for kids or for families with kids. Is that something that you think is feasible with the data? I don't know if it's only adults with long bone fractures.
They may have fallen out with our exclusion criteria.
Okay.
But as India mentioned, there's a big emphasis on the pediatric work through Utstein, so far as to include it in the sort of intermediate level collection along with the other bellwether procedures. I was happy to see that, but I don't think we collected below 18.
Mm-hmm. It's fascinating. Other questions?
The impact on the household from a pediatric procedure is enormous, so it's important.
Yeah, I mean, I suppose from a social standpoint, it's tricky because if you have a kid who's injured, then one or more parents have to go and be with the kid, and which obviously is going to largely be the non-working parent, because most families are likely to be single income. And then, it just sort of complicates things, right? And I just wonder what the cost of, like, how different the cost implications are for pediatric injuries compared to adult. But again, those are the kinds of things that you can't tell from hospital billing or like national billing data. You have to have survey data to really kind of understand those needs. Yeah, I think it would be.
Indirect costs are what's underexplored. There's like a parent took off work for 2 weeks to help take care of their kid. What was the impact there?
Yeah.
We're looking at the same thing in Mongolia, right? Because we reported Mongolia's catastrophic expenditure on bellwether stuff, and we included lap choles because we've sort of most of our work has been around introducing laparoscopy, and lo and behold, we found that maybe we're making a bunch of people financially stressed or impoverished because of the cost of technology in Mongolia passed on to the patient. And so we finally got the data now. We're looking at indirect costs and seeing if the reason we introduced this was to get people back to work faster and decrease indirect costs. So now we're finally able to see the impact of sort of minimally invasive surgery on that population.
Okay. Great.
Well, thanks everyone.
Comments, questions?
Yeah, that's a great point from Justina. Ghana just launched a national surgical plan. And so yeah, we're hoping to discuss that and sort of leverage our data. I think they were working with so while we were doing this, there was sort of a almost competing project with, I think, Operation Smile that was working closely with the Ministry of Health, and they were doing one of these sort of big national sort of cluster data collection prospectively. And so, but Dr. Jade was also on part of this. He's sort of linked in. So I think Dr. Say, that's a great point. I hope that we can inform their iterations in the future. Well, thanks for your attention, everyone, and India, wonderful job.
Thank you, everyone.
Yeah, great work. And for the next several weeks, next week, our fellow from Ethiopia is going to be presenting from Ethiopia. He's there for the next month or so. He's leaving tomorrow. And then we'll have Dr. Edward Sutherland, our site director from Ghana, presenting the following week. And then Dr. Skola Matovu, one of our nursing school faculty who has a Fogarty grant for work in Uganda, will be presenting at the end of this month for our global health research, multidisciplinary global health research grand rounds. So that's what's on the docket for the rest of the month. So if you can join us for it, that'd be great. So otherwise, thanks so much for making time today and have a great rest of the day. See everyone.